Good morning everyone. Today I'll be presenting a case on the title Mitomycin C, the resolution and the problem. No financial interests or conflicts to disclose. Introduction. Ocular surface squamous neoplasia encompasses a spectrum of epithelial tumors. Surgical excision followed by histopathological excision remains the gold standard for ages. Recently, medical therapy has an advantage of treating the entire ocular surface and decreasing the recurrence rate. The options we have include mitomycin C, 5-fluorouracil and interferon alpha 2b. Mitomycin C can be used either as a standalone as well as an adjuvant therapy. Adverse effects include conjunctival hyperemia, epitheliopathy, and punctal stenosis. This is a case of a 60-year-old female presented with complaints of lesion in a wide part of the right eye for the past 10 months, which was incidence in onset, not progressive, not associated with pain, with history of intermittent grittiness present. She had a previous history of similar lesion in the right eye for which excisional biopsy was done, and the HP reports were suggestive of ocular surface squamous neoplasia. Post 1 month after her excision, she recurred with the similar symptoms, and the presenting visual acuity was 6/9, and the conjunctiva showed a pinkish fleshy papilliform lesion of size 5 cross 2.5 mm along 2 to 4 o'clock position with a prominent feeder vessel could be seen here. And the ASOCT showed a hyperreflective epithelium with posterior shadowing and abrupt transition of the epithelium could be seen, and a diagnosis of right eye recurrent papillomatous ocular surface squamous neoplasia was made, and she was started on eye drop mitomycin C 0.04% QID for 4 days followed by a drug holiday for 3 days, and this was repeated with a 12 cycle and substituted with a preservative free carboxymethylcellulose. This is the 6-week follow-up image where you can see the lesion being resolved, and this is 3rd month follow-up image where the lesion resolved and with vascularity is also regressed and pigmentation could be noted. 2 months post MMC therapy, the patient presented with a decrease in visual acuity. Under examination, we could see the haziness with heaped epithelial margins, and the haziness was distributed up to the stromal level in a centrifugal pattern. On staining, irregular stain uptake was seen, and superficial vascularization was noted. Epithelial defect was diagnosed, and she was started on copious lubricants. But 2 months post lubricant therapy also epithelial defect persisted, so limbal stem cell deficiency was suspected here, and she went for epithelial debridement with amniotic membrane grafting and bandage contact lens. This is the 1 month post-op picture of the same patient after removing the BCL, where the haziness has reduced and there was no epithelial defect but pooling was present, and integrated AMG could be seen in the margins, and haziness and vascularization has regressed. MMC inhibits active keratocytes and exhibits non-specific cell toxicity. Incidence of limbal stem cell deficiency in patients receiving longer cycles has been reported. It can present as abnormal irregular epithelium with irregular stain pattern. Management in case of LSED include eliminating the offending agent, preservative-free tear substitutes, and band-aid contact lens. In case of refractory cases, AMT helps by forming a scaffold for re-epithelialization, anti-inflammation, and decreasing vascularization and scarring. Take-home points: MMC, an anti-metabolite, has its action specific to the replicating cells. This has also led to its toxic effects such as LSCD and persistent epithelial defect. Punctal occlusion and pulsar dosing can aid in reducing the toxicity, and further studies regarding appropriate concentration of MMC in suspected individuals are mandatory. Interferon alpha 2b is a safer alternative with lesser side effects. Thank you.
Thank you, Shubham. Please be ready with your PPT. So, Renukha, what was the duration for which you applied MMC?
Sir, we gave 12 cycles.
1 cycle. With that only there was LSD.
Yes, sir.
Okay. So, not, and you follow this
Because
1
maybe
cycle on of that pattern, right?
yes, sir. Maybe she had a history of excision also.
Okay.
That is also a contributory factor for limbal stem cell deficiency.